Hello everyone. Let's move on to discuss two common clinical conditions of congestion. Congestion of the lungs and of the liver. First, let's look at a case. This 69-year-old man with well-controlled type 1 diabetes mellitus presented with upper abdominal and lower chest pain of 4 hours duration and accompanied by shortness of breath and diaphoresis. An electrocardiogram revealed multiple premotor ventricular congestions. The terminal event was cardiac arrest. The key points of this case summary were upper abdominal and lower chest pain, shortness of breath and sweating, and the terminal event was cardiac arrest. These two pictures show the growth and histological appearance of the patient's lungs. What are the pathological changes in his lungs? Follow me to find out the answer. Acute and/or chronic congestion of the lungs is a common and serious complication of failure of the left side of the heart. In this situation, the left side of the heart cannot adequately pump the blood from the right ventricle. In acute congestion, the lungs appear increased in size and weight, dark red and swollen. Compressing the cut surface, pink foamy liquid can be seen. Where does the pink foamy fluid in the lungs come from? Let's look at the microscopic appearance of the lungs. Microscopically, acute pulmonary congestion has two features. One is that the alveoli septa become widened because alveolar capillaries are engorged with blood. The other feature is pulmonary edema, in which the alveoli spaces are filled with fluid. Focal minute intra-alveolar hemorrhage can be seen as well. Let's look at these two pictures. This is normal lung. Compared to the normal lung, acute pulmonary congestion is marked by blood-engorged alveolar capillaries and alveolar edema. The pink foamy liquid we saw while compressing the cut surface was due to pulmonary edema and hemorrhage. Besides the appearance we have mentioned in acute pulmonary congestion, chronic pulmonary congestion has two more morphologic features. The alveolar septa becomes thickened and fibrotic. The other is that the alveolar spaces may contain numerous hemosiderin-laden melophages. The iron from the red blood cells is converted into hemosiderin by the melophage and stored in their cytoplasm. These cells are often seen in patients with heart failure, so-called heart failure cells. Long-term congestion leads to widespread fibrosis of the lungs. Hemosiderin accumulation gives the lungs a dark brown color, and the patient can cough up blood sputum. Now let's look at these two pictures. Could you tell the difference between them and make a diagnosis? Well, in picture A, we can see dilated alveolar capillaries accumulated with red blood cells and pulmonary edema. In picture B, we can see alveolar septa become thickened and fibrotic and a lot of hemosiderin-laden melophages in the alveolar spaces. Then, what is your diagnosis? Yes, A is acute congestion of the lungs and B is chronic congestion of the lungs. Shortness of breath and congested in chest are two clinical signs suggesting pulmonary congestion. Acute and chronic congestion of the liver occurs when there is right heart failure or obstruction of the inferior vena cava or hepatic vein. In acute hepatic congestion, the liver increases size and weight and has a dark red color. Microscopically, the central vein and sinusoids are distended with blood. Liver cells closest to the central vein may be atrophied or even necrotic. The periportal hepatocytes experience less severe hypoxia because of their proximity to hepatic arterioles and may only develop reversible fatty change. In chronic congestion, the central regions of the hepatic lobules appear glossary red-brown and slightly depressed because of a loss of cells, and the surrounding rows are tanned, sometimes fatty. Microscopically, centrilobular hepatocytes show necrosis because of the poor oxygenation in this area. The surrounding rows near the portal area where oxygenated blood from hepatic arteries is better oxygenated. So the cells just showed fatty change. This results in a characteristic gross appearance called non-MAC liver, because the cut surface of the liver resembles the cut surface of a non-MAC. Now, let's examine the lungs from our clinical case. The key symptoms of this patient were upper abdominal and lower chest pain, shortness of breath, and diaphoresis, and he died of cardiac arrest. The left photo is the gross appearance of the patient's lungs, which are distended and red. The right one is the histological appearance. What are the arrows pointing to? They point to the congestion in the alveolar capillaries, and there is edema fluid in the alveoli. Now, what is your diagnosis? Well, considering the patient's clinical symptoms and the gross and histological appearance, the diagnosis is acute congestion of the lungs. The reddish coloration of the tissue is due to congestion. Let's make a summary about hyperemia and congestion. Both of them refer to an increased blood volume in a tissue, but they have different mechanisms. Hyperemia is an active process resulting from arteriolar dilation. Congestion is a passive process resulting from decreased outflow of venous blood from a tissue. The factors leading to congestion can be summarized as outside compression, inside occlusion, and cardiac failure. Cardiac failure leads to two common clinical conditions: pulmonary congestion and liver congestion. Hyperemic tissues are redder than normal because of engulfment with oxygenated blood. Congested tissue have an abnormal blue-reddish color due to accumulation of deoxygenated hemoglobin. Most hyperemia is temporary and resolves when stimulus is removed. On the contrary, venous congestion is often chronic. In long-standing chronic congestion, inadequate tissue perfusion and persistent hypoxia may lead to parenchymal cell death and secondary fibrosis. Here are the references and acknowledgement. Thank you for your attention.